Well, hello, everyone. I'd like to welcome you to a very interesting topic that has been gaining notoriety in the last few weeks in the media about treatments and preventive measures. And it's all about dementia, and it's all about Alzheimer's disease. And today, me, Dr. Neelum Aggarwal, and Dr. Monica Parker are going to talk to you about dementia and Alzheimer's disease. And what do we know about dementia and Alzheimer's disease? What is happening right now in the research world? And more importantly, clinically, how should you be thinking about this disease as your patients come to you with various questions about their risk? So before we get started, a brief introduction. I'm Neelum Aggarwal. I'm a cognitive neurologist at the Rush Alzheimer's Disease Center. I'm a longstanding AMWA member. Was AMWA's Chief Diversity and Inclusion Officer. And Alzheimer's disease is really my area of specialty that I've been practicing for many years in community-based settings, clinic, and research. I'm going to introduce to you a good friend of mine and colleague, Dr. Monica Parker, and she will introduce herself.
Yes, thank you, Neelum, and thank you to AMWA for allowing me this platform. I am by training a family physician and geriatric primary care provider. I now serve as the outreach, recruitment, and engagement lead for the Goizueta Alzheimer's Disease Research Center at Emory University. In this role, I educate the lay public and other healthcare professionals, to include family physicians or primary care physicians, nurse practitioners, pharmacists, and other learners about Alzheimer's disease and research opportunities.
Monica, thanks so much for giving the background of where you're at in Emory and, highlighting that you're also at a research center like I am. And I think that's an important thing to keep in mind as we talk about this, and you and I talk about Alzheimer's, but we're also talking to our docs that refer patients to our centers here in Chicago or down in Georgia, in Atlanta, about what they should know about Alzheimer's disease. Because frankly, you're on the front line. Patient asks you a question. And so we're really going to kind of run down some common myths about Alzheimer's. And we'll talk about how we think about it maybe in the same way or a little bit differently. So the first myth, memory loss is always Alzheimer's disease. Well, we've heard that before. It can happen, a casual comment in the hallway from a colleague, well, it must be Alzheimer's disease, got memory loss. But no, not all memory loss is Alzheimer's disease. And, the way I think about it is we need to find out what could be the reasons for memory loss. And over the years, we're suddenly beginning to really place a lot of importance on cardiovascular disease and a lot of issues with the heart that can be causing changes in thinking, that could be related to stroke or not stroke, that could be one of the big issues for memory loss. And until we understand how much the heart and or brain infarcts are there, we really can't say for sure if it's Alzheimer's. How do you think about this, Monica, when you hear about, it must be Alzheimer's disease?
I think that's where we in the Alzheimer's or the neurologic and Alzheimer's research space need to do a better job educating our colleagues. When I hear memory loss, my education piece is Alzheimer's is not just memory loss. If you've got memory loss, there's other stuff going on. And it's not always just Alzheimer's. And consistent with what you said, I had a neurologist, Dr. Gottsman, Rebecca Gottsman from the National Institute of Neurologic Disorders and Stroke, on our Brain Talk Live yesterday, talking about vascular components, as you've alluded to. If you have high blood pressure, if you have high cholesterol, those are things that make it more likely that you will develop some kind of vascular incident that contributes to your cognitive or your dysfunction, your brain dysfunction, that makes it such that you don't remember words, you don't have good physical capability. So I think that we need to start broadening our understanding of dementia and say it's not just memory loss, it's physical disabilities, it's difficulty planning, it is sudden, not sudden, but developing urologic and fecal incontinence. It's not always just because we're old and we have weak bladders. It's a neurologic disorder.
So, when we talk about memory loss, Monica, vitamins always come up in this discussion. Like, is mom or dad vitamin deficient? Is that the reason why there's this memory loss? And I think it's important, for you to share in your practice, how often are you seeing a vitamin deficiency causing a memory loss in an older individual?
I don't know that I would say that a vitamin deficiency is solely the cause, but it's usually a complex of symptoms, and a vitamin D as in dog or a vitamin B deficiency is often present. But not only are vitamin deficiencies present, there may also be some emotional overlay. Many of my older patients do experience depression, but they may not call it that. It is depression. It may be anxiety, but they are reluctant to say that they have depression. They may acknowledge some stress. And so, for the rest of those of us that are practicing, yes, we should be measuring and looking at vitamin D and B levels, but we should also be assessing for anxiety and depression, because we know that depression is treatable and symptoms of depression frequently manifest and look like dementia, but they're not.
And
It's
the
fixable.
thing is, right, you just think about this. If you have depression, your intake of food normally isn't good. So
No,
it's just feeding into a vitamin deficiency, right? Where
right.
basically you're not preparing your food, you're not eating. So again, I think it's an important thing. We hear this all the time. And then the thought is we're going to treat this before we start talking about dementias. But let's wind it back a little bit. And I get asked this all the time. Dementia and Alzheimer's disease, are they the same thing? And the way I explain it is dementia is like the title of a book, and Alzheimer's is chapter one.
That's a
Chapter,
good,
right?
I like that. I like that.
Because you
I've
can
never heard that
visually,
one.
okay, but you see it's a visual, right? And then
Right.
chapter two, let's say, is vascular dementia or mixed dementia, as we're saying. Chapter three is Lewy body dementia. So with these types of different dementias, when you're talking to colleagues right now, Monica, how are you explaining the differences? Because again, I'm very sensitive to my colleagues who don't have a whole lot of time in an exam room to be asking certain questions. How would you distinguish, or what's your go-to with your colleagues to say how we're going to figure this out if this is the kind of dementia we're looking at?
I think strictly from a primary care perspective, I don't always have the latitude, if you will, to explain too many different things. I'm really focused on, let's make sure that we rule out the things that we can rule out and make it easier.
Mhm.
If I'm in a didactic lecture, it's easy. My favorite graphic really is the pie chart, the
Yeah,
pie with the different types of dementia to explain it. Or you can use the Alzheimer's graphic that says, okay, dementia is an umbrella, and underneath
right.
this umbrella, we have all these different types. But the thing that I'm really quick to say, particularly in primary care circles, is that dementia is a many splendored thing. It can be a little bit of this, it can be a little bit of that, but unless you do a lot of examination and testing, you're really not sure what it is you got.
Exactly. And so the bottom line is it is a progressive disorder, first thing. Um,
Right?
it is, as you heard before, we try to rule it in, meaning we're ruling everything out that can cause it, and then say, okay, this is what we have. And now we're sitting with this diagnosis of a dementia where we're having difficulty with not only memory, but other areas of functioning, which you mentioned, right? Activities of daily living, self-care, et cetera. And then the third piece is when you talk about different types of dementia, number two is really coming up, and I would even dare say going to be number one pretty soon in this country, mixed dementia, where you have Alzheimer's pathology in your brain and you have another pathology in your brain, i.e. mixed, most commonly vascular. And,
I agree.
right? I mean,
I really agree with that. I think more dementia is less Alzheimer's and more mixed everything else.
exactly right. And I think, again, it complicates things a little bit because What that means is that, if you look at treatment for medication, if you have a mixed pattern, that means that treatment is only going to be able to hit a part of that pattern, right? And
Right.
that you're going to have to do multiple different things to combat that pattern of mixed. And this is finally how we're speaking about this. And for many people, it's the reason why, hey, we haven't had one drug to take this, eradicate this disease, right? So I think that, mixed is really important for people to understand. So if the doctor says mixed, and if you, as a physician saying it looks like mixed dementia, your patients are going to be hearing more and more about that. So I would say start using the term, start using that term.
And
Um,
and
Go ahead.
can I interrupt for? I
Yeah,
think this is where it's important for people to understand that chronic illnesses, the
yeah,
chronic cardiovascular diseases, frequently coexist in people with Alzheimer's. There's very little pure Alzheimer's. I've not seen it. All the pathology, autopsy studies on patients of mine who participated in research, they've pretty much all had a mixed dementia.
exactly. There's always been something in there. And I think, the other piece is, therefore, we've seen people who've had all these different pathologies, and many of them also have not developed trouble with memory. So it's not a normal part of aging.
No,
You and
not at
I have
all.
seen people in, 100 years old, cognitively intact, doing well. And then we've seen a 52-year-old that just is having a horrible time with everything, and we think it's a dementia. So this idea that it's part of a normal part of aging, that you're eventually going to get this, it's not true anymore. And I think it has
No.
a lot to do with this mixed pattern, that there are different pathologies operating at different levers, if you will, and some people are just doing very, very well despite of that, you know?
On that note, though, Neelum, I think
Yeah,
that one of the questions that has been posed is, well, how do you tell the difference?
right,
And it's not as simple as ordering just an MRI or ordering a specific blood test.
right,
And I think that what we need to appreciate is getting an accurate diagnosis of Alzheimer's or any other type dementia is a process of ruling things in and ruling things out. Just an MRI isn't going to help. Now we
exactly.
have the specialized PET scans, the amyloid PET scans, the tau PET scans that are helpful, and the blood biomarkers. But the blood biomarkers by themselves aren't as diagnostic as they
No.
probably can be.
So Monica, let's go back to this MRI. And how often do you get this? Well, can you tell if it's Alzheimer's from the MRI? And I'm always saying, no.
No,
From a clinical
no,
MRI, I mean, the MRI is being done to rule out other causes of the memory
exactly,
problem.
exactly,
So
exactly.
if you're a physician, you are ordering an MRI, or in some cases, you can only order a CT, and I appreciate that, based on what's happening in the body and devices and things. But you're ordering it to rule out, frankly, a tumor, a large stroke, an
Right.
infectious process that could explain why the memory problem is there. But from an MRI,
It's not
no,
diagnostic.
exactly. And I think that's, some patients say, well, can't you measure the size of the brain and different areas? Yes, we can, and we do it in research, but it's
Mhm.
not coming in like in a clinical space where you're saying, okay, this area of the brain, because it's this small or shrunk, is now, yes, this is consistent with Alzheimer's.
On
Um,
that note, though, Neelam, you're the neurologist.
right.
Are you doing, how often are you getting an amyloid PET scan or a tau PET scan on your neurologic patients in your clinic? I wouldn't order one as a primary care physician because it's not widely available in most
Right.
primary care settings. Outside
Exactly.
of an academic hospital setting, I don't know where I can get an amyloid scan.
Well, this is so true, and I think this is the unfortunate part. I mean, these scans again were done, predominantly in research. You and I both have done trials, and we know we've been using them in trials when we look at drugs. So if you're giving a drug to reduce the amount of amyloid in the brain, you need a starting point to find out how much do you have. So the amyloid PET came in to tell us the load, if you will, in the brain. And then you use the amyloid PET to monitor with that drug if the load is going down. And then ultimately, when you reduce the amount of amyloid in the brain, how's your thinking? I mean, this is what, our colleagues say to us. And I was just at a meeting and that was the first comment. Are these drugs really helping with cognition? So, the issue of ordering these amyloid PETs, it's not routine. Even in neurologic offices, the hospitals may not be equipped to do it. You may not be able to get the tracer. So that's why, Monica, you and I are seeing this, surgence of the blood biomarker, because, draw the blood, draw the tube, send it out and get a report back. But you and I both know those blood biomarkers are not as sensitive as we want them to be in people with chronic medical conditions. And
That's right.
right. And that's what we're concerned about. I think it's coming. And I think, our colleagues are asking about this out of curiosity about it, because, they're seeing, like you mean, you look at UC cancer, right? How many people are ordering different, markers for cancer? It's not like we don't do this, but for
Right.
cognition, it's tough, right? It's
We're
really,
getting that's where research comes in. We're getting to the point where we're developing better biomarkers for this disorder. While we have biomarkers, clear biomarkers for cancer, we don't necessarily have it for neurologic disorders.
right. Right. And I think, I think it's important that you're saying that, and I'm saying that we just have to proceed with caution. I'm very,
Agreed.
very concerned when it's like, this is the end all, this is what it is. And my answer is no, it's not.
And I think this is a good point because I've seen a number of physicians, whether they're neurologists or primary care doctors, trying to develop the concierge medical space, saying, well, I want to order this test and offer this study and tell them that they don't have things. And I'm like, well, that's really that's false advertisement. That's misleading. That's not really helping your patients any. So I would caution us that just ordering a biomarker and not doing neuropsych testing, not keeping the testing along with the radio imaging and the blood biomarkers, I don't think you can arrive at a proper diagnosis without the whole package.
Yeah, and I'm glad you said that too, because, and I think we're going to, I think we should pick this up again in a further episode where we can talk about the latest and what we're dealing with in our field about these biomarkers. But I think one thing here is that clinical relevance, right? And actually seeing the patient and doing what many of us are so familiar to do. And, it's an interesting discussion, Monica, because it's the same thing that's going on with AI right now. So this big discussion in medicine about AI and how AI is replacing so many different things. And yet, when you sit back and you think about it, yes, but there is still a clinical piece to it that should remain in that workup, if you will, not just AI and order a test, right? So we're
And
having this on multiple levels, right, in medicine.
you still got to talk to the patient. You still have to talk to the patient's families, and you have to use your own clinical discernment. You can't just plug something in. And I think that I won't get into a philosophical discussion about how we're training our providers, but it's wrong to think there's an instant test that gives you the entire answer. Medicine is an art, and it's about looking at the patient, touching the patient, getting the history from the family and the patient to make the right diagnoses.
Let's just talk about this. This is another myth that comes in. Well, Alzheimer's is not that fatal. Okay. And meaning, okay, it's Alzheimer's. And you've heard this. I mean, you've heard people say, well, she just has Alzheimer's. And I'm always thinking, yes, she also has Alzheimer's, and what it can do to the body system makes the body system failures occur, right? So Alzheimer's is affecting, the respiratory system, the GI tract. It's a neurodegeneration that affects the body. So yes, Alzheimer's is fatal. And, the number one, right now, the number one disease we have in this country is cardiovascular disease, right? More people still are dying of cardiovascular disease. And you can imagine what you just mentioned in the beginning. And even with Dr. Gottesman, right? How much cardiovascular disease is on top of Alzheimer's disease. So it is a double whammy for us, isn't it?
I think it's a double whammy, but I think the thing that you just talked about that I think is really, really important is that Alzheimer's may not kill you, but what it doesn't allow you to do will. If I've got advanced dementia and I am forgetting to eat, starvation, dehydration are things that kill you.
It's exactly right. It's exactly, and it's well said, very, very well said. And I think that's a key message even for our physicians. Well, we're doing all this, and she has Alzheimer's disease. Just remember the neurodegeneration and the impact of that is now accelerating everything else, right? And so
Right.
we're very well said, very, very well said. So let's talk now a little bit about risks, right? I mean, forever you and I have been in the research area and world talking about risk factors for Alzheimer's. And for some of my colleagues, they sometimes say, "Oh gosh, everything seems to be a risk factor with you guys," meaning, in the aging world, everything seems to be a risk factor. But let's talk about what we say to our patients about risk and what we can do for risk reduction. That's the key. So let's age.
Okay,
Um,
age and sex are things we can't really alter, but those
right?
are some of the key risk factors. We do know that the older we are, the more likely we are to discover this kind of dysfunction. But I'm going to go back to something that I think is really, really helpful for those of us who see patients. The Lancet Commission report. It's a consensus article, and I know some people may agree with it, some people may not agree with it, but it's been updated since 2017, most recently 2024, and we found that there are 12 different things that you can do that decrease your risk of developing a dementia. And the things that we can work on are the things that we need to manage. And on that list are things like managing your hearing loss, managing chronic conditions, getting enough sleep, addressing sleep apnea, addressing depression and anxiety that we've talked about already. So I'm trying to think of some of the other things that
Well,
are more common.
the latest one, right, Monica, was the head injury, TBI, limiting
That's
the.
right.
I mean, and that's huge. I just want to talk a little bit about this head injury. So when we
Yeah.
say, MTBI, by the way, concussion now is being replaced with the term, at least the way I'm using it as a neurologist, mild traumatic brain injury. And it's an intentional use of the term to make people take notice and sit up. And it's not a little concussion. He had a little, no,
No.
he had an MTBI. And if that's what's going to take for people to take it seriously, then I will say it over and over again. But just
And
think, right? How many falls?
well, that's a good one. In older adults, falls, hitting
Right.
your head, things you think are innocuous. Domestic abuse. Yeah, those people get head injuries too. Military veterans, but being more on the ground, boots on the ground, if you will, with geriatric patients, we fall a lot. Falls are big
Exactly.
issues in geriatric patients. And how many times do we hit our head? I've had patients that
Exactly.
have
Exactly.
fallen or had a head injury and getting very, very suddenly confused. And then they end up in the emergency room. We find that they've got a subdural. They've got a
Right.
subdural
Right.
because they've hit their head
Right.
somewhere, and nobody seems to understand where that happened. And this is particularly common
Right.
in older
Exactly.
adults who
Right.
live by themselves. I mean,
Right.
I'm just thinking of the one
Oh, yeah,
person.
totally. And the other thing too is, you know, if a patient is telling you as a physician that they've had a fall, you can best assure there's been more than one. This is one of those
Right.
things like with alcohol, intake, it's always underreported. It is never overreported, folks, and you have to understand that. Oh, I fell last week. Have you fallen before? Well, it was a while. No, it's more than one. And that means from a clinical perspective, should we be going for balance testing? Should we be doing the exam again to see if there's Parkinsonian signs, occurring? You need to take this seriously because this is one of the things that came in that Lancet Commission this time about falls. And I was so happy to see it with the TBI. under the TBI and trying to a preventable cause, if you will, for dementia.
Well, I like the idea of trauma and falls, but you mentioned something a minute ago. Let's talk about alcohol use. And I live in the deep South, and people don't think a whole lot of having a little cocktail with your dinner. And grandma has 3 fingers full of bourbon once or twice a night, but then when you keep talking to them, they have more than 3 to 4 fingers worth of bourbon. They get whole tumblers full. And I say that because
Yeah, I
that
mean,
was
in Chicago, we always ask the size of the glass, Monica. I never ask how many drinks. I always say, show me the size of the glass, and then you get a very good idea of what people are drinking, right?
and then they say, well, it really wasn't that much. I
Yeah,
only had
totally.
one.
Yeah.
And then they fall down sloppy drunk, but they
Yep.
wouldn't call it that. In
Right.
genteel society, we wouldn't address our drunkenness, but let's be real. We do drink.
Yeah.
And it may be social, and if I'm drinking alcohol and taking medications whose effect may be exacerbated or made a little different because of my alcohol consumption, I just think the common things being common are the things that we need to pay attention to as physicians and other people seeing people. Just because it looks like a duck and walks like a duck doesn't mean that it is.
But I do think, when we talk about and again, it's a very touchy topic, isn't it? Right? About the drinking. But here's how I couch it. I understand you like a cocktail before dinner. I understand that you may want wine with dinner. I'm just going to tell you, if you do that, your thinking and your memory is not going to be good. So
Right.
sleep will be disrupted. And so I try to lay out the facts. Your sleep will be disrupted. It will be fragmented. The next day, you're going to wake up, and if you have something to do the next day that means something to you, I would not be drinking the night before anything. And your thinking is not going to, your thinking is not going to be good. It it doesn't make you, you may feel it's making you more relaxed, but how you present yourself and accuracy of what you're saying isn't good. And sometimes that's enough for patients to say, okay, I don't want that. I don't want that to happen. I don't want to look like that. I don't want to look like I don't know what I'm talking about. Okay. But I do think, getting back to the important article from the Lancet, because now we're all talking about it. And I think what I liked about the Lancet is from neurology all the way to primary care, family medicine, geriatrics, and to an extent, even psychiatry, we all kind of got a level playing field here on what we're talking about, that we all can address something, right? Here,
Right.
that we have to optimize these because you can do a good risk reduction for dementia if you optimize things versus saying that it's coming, it may come in your family, or it has in your family, and you're going to get it. So exercise right now, exercise and socially being active. How much are you stressing that right now in your practice? And are your patients asking you about data?
Well, it depends upon the audience. Okay, if it's a group of retired educators, they're asking, what evidence do you have? But if it's somebody who's not necessarily a retired college or other educator, they're going to want to know, well, what can I do? What can I do? And so we talk a lot about exercise. In fact, most of the public programs that we conduct at our Goizueta Alzheimer's Research Center have exercise built into them, just because it's fun and it's sort of like you can do this for 10 or 15 minutes a day. You can do
Right.
something that you enjoy, because exercise, social engagement are things that are within the power of all of us to do. And those are the things that I stress. So I like the Lancet Commission article, not the least of which is because they have a great graphic and you can look there.
Right.
And when people,
Right.
I don't want to give people all the answers. I want you to look for the answers your daggone self. You can look
Right.
this up. This is
Exactly.
something simple.
It's
It's not my job to do everything for you.
right.
I can guide you,
Well,
but
that's
it's not
true. I
my
mean,
job to do it all.
right. But having said that, and again, you and I have done a lot of community work and we're in the community all the time. You want to empower people and give them the tools to show them how they can make it happen. But you're right, they have to make it happen, right? And
Right.
they do, and many people do. I mean, for exercising, it's so interesting about the data on exercising and what's coming in about exercising. Walking still remains, and resistance training, of course, is important as you get older. Stressing, the muscles and better bones. But walking is what I just was in clinic yesterday, and I said the same thing. You just do this for me while you walk. I just need you to walk.
Yeah,
I need you to walk.
it's free.
Exactly. It doesn't cost you anything. You don't need to be paying any fancy clothing. You just need to walk. And the data on walking is so good. And, let's talk a little bit, Monica, switching also to women. You get this, I get this. Are there differences that we're seeing with women with certain of these risk factors? And I think let's go back to alcohol. Alcohol for women is not good. That's it. That's all I'm going to say on it. If you drink and you're a woman, it's just not good for you. It's not good for you on multiple levels from a cardiovascular perspective, on a cognitive level, but there are sex differences here. And I think people need to understand this, that yes, we are not little men. Therefore, what is good for
No.
men is not good for us. And when it comes
Mhm.
to brain health, we have to really be a little bit forceful with our women. No, there are differences here. So alcohol's the first one. What else do you talk to your people about when it comes to sex differences?
Well, the question I get a lot is, what about my hormones?
Mm,
And I think research is still being done to understand what role estrogen plays in the development of dementing or neurocognitive disorders. I
right.
still think there's a lot of research that's being done. I don't think there are any definitive answers, but women's hormonal issues
Mm-hmm.
may figure into the development of some Alzheimer's. It's like, well, I'm going to say a generation ago, a lot of the women continued to take estrogen because it made their skin pretty. It
Mm-hmm.
improved vaginal lubrication and made sex more interesting or more fun.
Mm-hmm.
We used estrogen to keep us appealing to our partners. Well, now we're learning that prolonged estrogen, particularly if it's not organic, um, added estrogens are detrimental.
Yeah.
They're not good things to continue. So, research is still ongoing with
Yeah,
this, but
I think we should have a follow-up conversation on this topic because what I'm happy to see is this discussion of the perimenopausal stage.
right,
And the hot flashes, finally, this is coming into a little bit more mainstream because we all would see this, right? You would be out there at the drugstore or you'd be out there public and you'd see a woman having clearly this hot flash and what's happening with them. The sweating, the profuse sweating, the uncomfortableness, the constant, I'm just very uncomfortable. That can't be good for the body, right? Anybody
no,
seeing that can say this cannot be good. There's clearly something happening with the body, the vasomotor response, the heart rate. And I'm happy to see that talking about how can you reduce those symptoms, whether it be through hormonal therapy or not. But I think we should be talking a lot more about this with women because the data still is showing that women in Alzheimer's, it's an elevated risk compared to men. You and I
right,
have been in, you and I have been in meetings where we've heard the reasoning, well, women live longer than men, therefore we are approaching that age. But it's
nope,
like, no, no, there are clear other areas that we need to investigate. Why is that happening on a biological
yeah,
perspective? Yeah. So
we're
we should
still we're still working on it. Is the answer?
absolutely, absolutely. Let's talk about family history. I get this quite a bit, Dr. Aggarwal. I'm here to see you. I brought mom in. Great. Talk about mom. Now talk about me. And I think it's a very fair kind of, you get this kind of a dual thing in a clinic type of visit. Okay, you've
Well,
diagnosed her, but what about me? What about my brother? What about my other sister? How do
well,
you approach family history?
I think the way I personally approach it is up until very recently, people who had dementia. We don't really know what they had, and we didn't have any evidence. So if I'm seeing your mother, and we know that your mother's been definitively diagnosed with Alzheimer's because she's got the protein precursors they found in her cerebrospinal fluid, or she's had a positive PET scan, I am looking at you a little differently. And
Mhm.
it, as we learn more, it may be the use of a monoclonal antibody is something that we would give somebody who doesn't yet have that symptom, but may be asymptomatic, excuse me, but is at risk. I don't know, but I think that I don't really like people to focus on so much the hysteria of my mother has it, I'm going to definitely get it. First of all, unless you've done a genetic study and we don't know, other than the ApoE3 and 4, that's one aspect of the genetics that may be contributory to Alzheimer's. But there are other genes that we're looking at, and I don't know that we have enough information about all the genes that may figure into the development of Alzheimer's,
Mhm.
um, or some other dementia. Maybe it's Parkinson's. I don't know. But
Right.
I think that the genetics, I think that the thing to focus on with families, getting back to the cardiovascular diseases, are what is it your mother has in addition to her dementia? Are you
Exactly
being
right.
treated for high blood pressure? Are you being treated for diabetes?
Right.
Are you being treated for heart disease?
Right.
Those kinds of things we have an answer for. We have a preventative for. So it's sort of like personal story. My mother definitively had Alzheimer's by diagnosis. Her pathology was very mixed, but I'm kind of like, okay, what can I do for me? Well,
Right.
I'm not diabetic. I'm not hypertensive. I am a little overweight, but I'm also a woman of color. And we don't have enough research going that really tells you enough about somebody like me.
Mhm.
So I encourage people to participate, but I want people to focus less on the genetics and more about what other chronic conditions does your relative
That's
have.
exactly right. That's
And
exactly right. And I think that's the messaging. What can you do to change the things that you are
yes,
in control about versus the genetic risks that, yes, of course. We do this in the clinical history. We ask about
yeah,
what runs in your family. We're doing it already. But to hang your hat on that definitively for the majority of these cases of Alzheimer's, I think is also wrong. So I have one last
I
topic I want to
agree.
bring up before we close for today. Clearly, you and I have to have another conversation because it's so good to hear your perspective on what you're seeing, and what your patients are asking
Right.
you, and what's happening up here in Chicago. There's been a lot in the news about vaccines and aluminum, and that was always there. By the way, this isn't something new. I remember entering this area even in medicine when I was a resident and hearing at Neurology, the issues with a potential vaccine cause of developing Alzheimer's disease and or aluminum. How do you feel about both of them right now, or are you following this kind of research, or what are your thoughts?
I mean, I reject it just because I reject it. If we're going to blame aluminum, that means everybody needs to stop drinking their cans of Diet Coke, their Pepsi. They need to stop using their deodorants because aluminum is there in all of that. Uh, so I'm not on the aluminum bandwagon.
Hmm.
But on that note, though, we do know that there are certain um, toxins. If you want to look at toxins, air pollution is now
Hmm.
being found to be an etiologic risk factor for developing dementia. I didn't say Alzheimer's, but it is a risk
Sure.
factor for developing dementia. I don't know that we've done enough research to really understand the effect of heavy metals.
Right.
Um, there are certain metals that can cause a poisoning, mercury poisoning, lead poisoning can cause neurologic disorders. I mean,
Absolutely. Yep.
so that's stuff we know.
Right.
So,
Right.
if you live in an area that has high lead, what was the trouble in Flint, Michigan?
It
It
was
was
the
lead,
water. Yeah, it was water. The
water.
water problem. Hmm.
So let's look at those kinds of environmental contaminants and pollutants in your geographic area.
Right.
Those things we know are associated with neurologic deterioration.
Exactly right. Exactly. And yeah, I mean, we've known this again in neurology, as you said, whenever you have a peripheral nervous system issue with your muscles and nerves, what are we doing? We're running for metals. What
That's
have you
right.
been exposed to? Is this an issue? This came in, and again, I just for the physicians who may not have been following this, Parkinson's. from a neurologic perspective, neurologic disorders, Parkinson's, way back, we were talking about pesticide use and people who were developing Parkinson's, and as there's a higher risk in farmers, higher risk in people in the agricultural business, were they somehow showing this type of disorder? So I think there's some links, and this kind of brings it up, right? When you do epidemiological research, okay, which, I've been very fortunate to do my whole career, and you've been involved in you know about epi studies and understanding them, but the epi studies and the results from epi studies don't necessarily translate into the clinical kind of research that we see. And that's been the issue, and it's a problem. So all I can say right now to my people is that when you're looking at viruses, those are from a lot of epi kind of related studies. Were you exposed to viruses when you were younger? Did you get exposed later? Like coronavirus is coming top of mind. We are still going to be understanding how that has affected the brain over time as people are now survivors of that and how their brain is aging. Okay. But it doesn't, it's still out. I guess I'm just going to say the research is going on, but there's nothing definitive. Yeah.
We don't have enough evidence. We don't have enough evidence to really give an answer for some of that. But, you talked about heavy metal testing. I think that in your geographic area, if you live in a farm area where there has been heavy pesticide use, is there a high incidence of cancer? What is going on that is problematic in your community? And those are things that you need to think about as well. We can't always jump to Alzheimer's is caused by this, Alzheimer's is caused by that. We know that Teflon is in everybody's system and it's bad for us because it causes cancer and a whole bunch of other stuff. Okay, but I don't know, neither does any of us know the ultimate effects of what was the contaminant in our environment, wherever it was we grew up, wherever it is we've lived for the last several decades. We don't know all of that information, and that's why research is important in this space.
And I think, and that's the other reason, just even talking, today, you and I talking, we're going through all these different things that we are understanding as it comes under dementia and for Alzheimer's. But I just want everyone to think about this. If we're talking about all this from the research and what we're seeing, you can imagine the reason why we don't have one drug or one type of prescription for this to eradicate it, because it's so many different things that are layering on, and therefore I've said this many times to my patients, it's going to be a cocktail approach of how we're going to treat this, right?
You're going to have a chemical cocktail similar to HIV, similar to cancer. You take a combination of medications.
Right, exactly.
And we're just Alzheimer's and related dementias aren't at that space yet.
Exactly right.
We're there for cancer. We're there for HIV. I started medical school, I have to say almost 40 years ago. And it's sort of like HIV was something to be avoided, but we didn't have any treatment for it then. Exactly. So I suspect in the next 10 to 20 years, we'll have a combination therapy for some of these disorders.
Right. And that's what we want. And I think everyone is going to have to get comfortable in that idea of a combination therapy from a provider perspective, from a physician perspective, to the patient. You have to sit in this and to realize that this is where it's headed. And we're going to be very intentional on what the prescription will be. But these reversible or these modifiable risk factors, take them seriously. And I guess I'm going to wrap up with that, right, Monica, to all of our colleagues in various fields. Take this seriously. Every chance you get with your patients, talk about it.
Lifestyle modification. Right. Lifestyle. Modify your lifestyle.
Modify this because it's helping your brain, so that if these things occur, at least you're starting off with, a full deck, like, hey, you did what you could. And if things happen, then hopefully by that point, we'll have the medical cocktail available.
Yes.
All right. Yes. Well, listen, I'm going to wrap it up for today, Monica. Thank you so much for joining. I think we're going to take a look at some of the topics and come back again. We're going to keep this convo going. We need to keep this going because the field is changing so quickly on our side about what's coming out from a diagnostic, treatment, monitoring, clinical trials that, I know that many of our colleagues are just saying, we don't even know where to start. So we're hoping we can get everybody kind of on the same page at the same time.
I think this is where we focus on what we do best.
Exactly. All right, well, take care. Thanks everyone for joining us today. If you have any questions, please let AMWA know and just type in, we want to hear more about this. But again, great friend and colleague. Appreciate you, Monica, and thank you so much for joining. Bye-bye.
Thank you. Bye-bye.